check up the first suspected anemia during pregnancy.
In these sessions, we are going to discuss about this acyanotic and cyanotic congenital heart disease and how you should proceed and how are the different picture you can look through this echo that will be discussed by the Dr. Monesh Tumar. Ma'am, please.
Okay, in continuation with the sequential analysis, we have discussed AV concordance connection, how to define the right atrial, left atrial, right ventricle, left ventricle. Just continuing, here we are seeing the patient of situs solitus with AV discordance. So by seeing this view, you cannot use the term corrected TJ or the LTJ. Definitely you have to ask about the situs. I know it is left atria, it is right atria, and here you will look at the offsetting. Look at the offsetting. This valve is more apically placed. It has attachment to the ventricular septum. Okay. This is very smooth, this is comparatively rough. So here the information from this 4-chamber view you are getting is the AV discordance. Outflow we have to define whether it is VA discordance also leading to corrected transposition. In the AV discordance condition, left-sided valve means which is tricuspid valve now usually is dysplastic, which is in 90% of the cases in the series, autopsy series. Functionally abnormally around 50 to 60%. So here you are seeing the TR of tricuspid regurgitation, which is now left-sided place. So it is a echo of the corrected AV discordance. Here AV connections which you are seeing is the both AV valves are connected to the one ventricle, which is morphological left ventricle. So double inlet, here we call it as a double inlet left ventricle. We have seen AV concordance, we have seen AV discordance. Now it is the single ventricle physiology, means double inlet to the one chamber, which is morphological left ventricle. LV we have to define by the same criteria, means smooth chamber. It is posterior located. Whatever the concordant discordant connection, LV has to be posterior. It does not come anteriorly. So and plus a smooth wall surface. Okay, so we have to define LV by that, and both AV valves are committed to one chamber, leading to double inlet to the morphological left ventricle. Sorry. Here what you are seeing is here aorta is on the right side. So by this it has to be situs inversus. This is one atria, another atria. AV valves are, this component is atretic, only one patent. So basically its connection is going to the one ventricle, morphological single ventricle. So here is the common inlet with atretic right component, which is committed to the one ventricle. Again, it's a single ventricle physiology. Here your right-sided valve, which is tricuspid, is atretic, and this is the mitral valve joining the left ventricle. So AV concordant but atretic one component. Here univentricle AV connection is because of the atretic one component. Here you are seeing the mitral atresia. Left-sided AV valve is atretic. This is right ventricle. Left ventricle was hypoplastic, not seen here, and LA is dilated. From this view, the most important information I am getting is this valve is atretic, obviously, single ventricle, but it is hugely dilated. Septum is going towards the LA, means atrial communication is restrictive. Means this child, if we go for the intervention, will require septectomy or the balloon atrial septostomy, because LA pressures are very high. Septum is just going towards the right ventricle. So from this 4-chamber view, I am getting the information. Single ventricle physiology with restrictive interatrial communication, LA is dilated, pulmonary veins are too prominent because of the pulmonary venous hypertension. Here in this 4-chamber view, the information I am getting is the AV concordant, but this valve is attached. This is interventricular septum. This is a left ventricle, morphological, it is smooth. This is right ventricle. This AV valve, which is tricuspid, is attached to towards the left side of the interventricular septum. There is large inlet VSD and it is attached, means straddling grade 1 to 2 is occurring here. Okay, straddling grade 2 is if it is more than 1 centimeter. It is attached at the septip, it is straddling grade 1. Then within 1 centimeter, then if it attaches to the opposite side, it will be the grade 3 straddling. Grade 3 straddling means it is going to the single ventricle physiology. Here we can detach it and close the septum like this. So patient will go for the 2 ventricle correction. So large VSD with straddling. We have to identify straddling and overriding. Overriding means commitment of particular valve, whether it is semilunar or the AV valve, to over the septum to other ventricle. So if we look from the overriding point of view, this is ventricular septal plane, this is atrial septal plane. So there is override also, because this plane will go here and it is towards the left. So there is overriding 25%, grade 1 straddling, but patient will go for the 2 ventricle repair. So these connections are very important. Concordant, discordant are important, univentricular, single ventricle, unbalanced are important, plus this overriding, straddling. What is the cause of unbalanced connection? We have to identify while looking at the echo. Here, like we know, tricuspid straddling best seen in the posterior plane, means in the 4-chamber view, because tricuspid valve is the posterior valve. For the mitral valve straddling, mitral valve usually straddle from we get from the outflow view. So this is mitral valve straddling, this is the ventricular septum, and it is going towards the right and attached on the opposite side of the ventricular septum, on the RV side. This child underwent Fontan operation finally. So it is leading to the single ventricle physiology because it is too far to bring to the left side of the ventricle. From the concordant, this was the AV connection. Then to the outflow sequential analysis, VA concordant we have seen, means aorta rising from the LV, pulmonary artery from the RV. So concordant connection we have seen. Here is the discordant connection. This is right ventricle, you can identify by this rough surface. This is left ventricle, and this is the aorta. This is the aorta, just going above, and we are not seeing any bifurcation. This is the coronary artery rising from the aorta. So aorta is arising from the right ventricle. Here, same child, you will see this is great vessel, semilunar valve you are seeing, which is bifurcating. So at this level, you cannot see it is aorta or PA, but if you follow the artery, the great vessel, you will see it is bifurcating. And this red flow coming to the PA is the pit inductus arteriosus. So this is a child with the transposition of great vessels with intact ventricular septum, small PTA. And transposition of great vessels means you have to go from the situs, situs solitus, AV concordance, VA discordance, and then relation of the great vessels. Here is the double outlet right ventricle. This is left ventricle, this is right ventricle, this is aorta, and it is more than 80% committed to the right ventricle. Only outflow from the LV is this VSD. So this VSD is very important. Size of this VSD is very important to the aorta because this has to route in this way. This will be the only LV outflow, may need enlargement if it is smaller. Okay, so LV, aorta we have to close in this way, intracardiac routing which we call. Okay, and the pulmonary arteries are this. So pulmonary artery is 100% committed to RV, while the aorta is 80% committed to RV. So this is a case of double outlet right ventricle. Aortic valve attachment here, mitral valve here, so you are getting the mitral aortic discontinuity, commitment of aorta. But it is a correctable lesion, you do not require any conduit or something. VSD can be routed to the aorta, pulmonary artery already committed to the RV, normal related great vessels. So child underwent surgery like a VSD. Here again due RV, this is the aorta, this is mitral valve, aortic valve, and this is severe pulmonary stenosis. Pulmonary arteries were committed to were posteriorly, and pulmonary stenosis because of the malalignment interventricular septum. Again a case of the DORV with the single ventricle. This is aorta, this is pulmonary artery, both semilunar valves at the same level. In DORV, the important thing is the both bilateral infundibulum. Means infundibulum, normally there is infundibulum below the pulmonary artery means RV has the infundibulum and not on the LV side. When it is double outlet right ventricle means both great vessels will have infundibulum, subaortic infundibulum, subpulmonary infundibulum. So because of these infundibulum, both great vessels will be, both semilunar valve will be at the same level. Sorry. So this is aortic valve, this is pulmonary valve. Normally aorta is at the level, lower level, and pulmonary is at the higher level. Here we are getting both semilunar valve at the same level. Then we have to look for the aortic stenosis or the pulmonary stenosis. Here this is the double outlet left ventricle, which is very rare anomaly. What we are seeing, very small chamber here, which is hypoplastic right ventricle. Left ventricle main chamber is this, and both great vessels, one semilunar valve is this one, which is aorta, which is pulmonary artery. We do not know in this view, but we are seeing two semilunar valve. There is no infundibulum. It is not neither below the aorta, neither below the pulmonary artery, which is a feature of the double outlet left ventricle, because LV does not have infundibulum. So double outlet left ventricle usually do not have any infundibulum. Both great vessels at the same level again, but here because infundibulum is not there. In DORV at the same level because there is bilateral infundibulum, both are higher and at the same level. Here both are lower at the same level because there is absence of infundibulum below the both great vessels. Then is the single outlet, large VSD, pulmonary atresia. This is the pulmonary atresia blind pouch. And this is the truncus arteriosus, means single outlet. This is truncal valve, this is VSD, left ventricle, and aorta is going this way and pulmonary artery rising from this going this way. So this is the truncus arteriosus. So in sequential analysis we have seen the concordant connection, discordant connection, double discordance means AV-VA discordance. We have seen univentricular AV connections. We have seen outflow with discordance, double outlet, and the single outlet, and the truncus arteriosus. So at all level, all connections abnormality we have seen. For the shunt lesions means ASD, VSD, PG, aortopulmonary window, atrioventricular septal defect. So these are the shunt lesions where echo give most of the information. The cath only required when there is question of the operability for the hemodynamic assessment. So whatever decision, main decision we have to take, we go by the echocardiography. If it is plus minus operability, we add cath, but your anatomy is by the echo only, which most of the information by the echocardiography we used to get. We can see the shunt at the level of atrial septum, whether it is ASD fossa ovalis, it is ostium primum, it is sinus venosus, SVC or IVC type, or the coronary sinus type. So what type of defect we will be able to define by the echocardiography, and then the direction of shunt and the PA pressure, the rest issues. Then at the ventricle level, type of defect, size of defect, what is the hemodynamic issue, AV canal defect, again type of AV canal defect, operability or not, there is associated rigors or not, PDA, size of PDA, and where it is connecting to the pulmonary artery. So these all things we get from the echocardiography only. In addition, we get hemodynamics. While on the obstructive lesion, we will see by echo only we can define it as RV outflow obstruction or the LV outflow. What is the severity of obstruction? What is the type of valve, calcified or not? Then the subvalvular, valvular, or the supravalvular. So everything we can get from the echocardiography, and the associated lesion obviously we can define. These are the echo picture of all type of the ASDs. This is the fossa ovalis ASD. This is subcostal sagittal view, and defect is there. This is left atrium, this is right atrium, this is pulmonary artery, this is SVC. The thing in ASD patient we have to see is whether patient can go for the device closure or will require surgery. Surgery obviously can be done for the any type of defect, but device closure for the fossa ovalis ASD only, and we need a central defect there. So the problem here is that our SVC rim is very small, so not a good candidate for the device closure. ASD is biggish, but biggish is not the issue. Our issue is this SVC rim. So we have to define the rims, means supporting structure from all views, for whenever we are deciding whether we can go for the device closure or the surgical closure. So fossa ovalis ASD, it is very important to define the rims, size of the ASD, direction of the shunt, PA pressure, effect of the ASD on the heart. So we have to take the information in totality whenever dealing with the fossa ovalis ASD. For the coronary sinus ASD means unroofing of the coronary sinus. So whole of the blood of the coronary sinus directly drain to the left atrium, leading to the feature of ASD and the cyanosis. So ASD will be seen in the lowermost part of the atrial septum, and no coronary sinus here. So coronary sinus, they are left SVC to left atrium, and this is the level of the atrial shunt. Then the sinus venosus ASD, SVC type. SVC type means SVC, this is SVC which used to override the defect. So the central part will be intact, means fossa ovalis area will be intact. You will get evidence of the RARV dilatation, means volume overload of the right sided chambers. Plus you have to look, whenever you are getting these things, means RARV dilated, you should look for the ASD. If fossa ovalis area is intact, you should do a subcostal sagittal view to look for the SVC for the ASD. Means you have to rule out sinus venosus ASD, whether SVC or the IVC type. IVC means IVC is committed to the is overriding the defect. In addition, both these defects have anomalous venous drainage of the pulmonary vein. Right upper pulmonary vein with the sinus venosus SVC type ASD, right lower with the IVC type of the ASD. So pulmonary vein anomalous drainage is usual feature of this type of defect. But definitely you have to look for the, it is very common for us to get a child with sinus venosus ASD with report carrying dilated RARV, primary pulmonary hypertension, intact atrial septum. It is very common to get this report. So before labeling intact atrial septum, we have to rule out sinus venosus ASD. These are the echo picture of the complete AV canal defect. You can see ASD, VSD and the common AV valve. This is the common AV valve, which is usually very beautifully defined from the subcostal. This is the coronal view, this is the coronal view, this is the sagittal view. So this is complete AV canal defect and balance connection. Means left sided component is connected to LV, right sided to the RV, and child will undergo total correction. This is the different type of the VSDs. This is perimembranous VSD. Here it is the tricuspid valve which is coming into the ventricular septal defect, and VSD is getting slightly smaller by this septal leaflet. Otherwise VSD is this big. Very large VSD getting slightly smaller by the septal leaflet of tricuspid valve. This is aorta, this is LV, this is LA. So our usual parasternal long axis view, and there is ventricular septal defect. Okay, this is the very important to define this VSD. Here it is usual perimembranous VSD as this one, but if you look carefully, this part ventricular septum, infundibular septum is posteriorly directing. In this condition, it is very high chances to have arch interruption of the coarctation of aorta, because during the fetal life with this posterior malalignment, LV outflow decreases and chances of having coarctation or interruption are very high. So whenever you see posterior malalignment of interventricular septum, means practically it is subaortic stenosis, chances of coarct and interruption are there. Usually presentation is in the newborn period, because by this posterior malalignment your left to right shunt increases, huge left to right shunt, and very early presentation. This is subcostal paracoronal view. Here what you are seeing, this is tricuspid valve, this is RV, this is right ventricle, this is aorta in short axis. This whole is a large VSD. Large VSD, dilated pulmonary arteries, and usual perimembranous VSD extending to the outlay septum. Here again this VSD defining is very important. It is the usual parasternal long axis view, LA, LV, aorta, aortic valve. If you put color here, you will get a turbulent jet, restrictive flow. LV is not dilated, but the important thing here is this prolapse. It is very important to label this prolapse, because child will have aortic regurgitation which will progress if you leave him on follow-up, and ultimately he will end up with the aortic valve replacement. So identify early stage of aortic valve prolapse is very important. Quantity wise VSD will be smaller, but it is at the risk of aortic valve damage. You have to define this aortic valve prolapse, you have to label it, and close follow-up if there is no AR. If AR develop, early surgery will require. We cannot advise follow-up with VSD getting restricted by the aortic valve prolapse. Then defining these echoes, anatomy, we have to look for the hemodynamics, means PA pressure should be assessed, quantum of shunt by the chamber size should be assessed whenever defining a shunt lesion. Then after this shunt lesion come the cyanotic heart disease, where tetralogy is the commonest type of cyanotic heart disease. Tetralogy physiology means you have VSD PS physiology. It will have tetralogy of Fallot, double outed right ventricle with VSD PS, Then TGA with VSD PS, AV canal defect with pulmonary stenosis, single ventricle physiology with pulmonary stenosis. So all these with pulmonary stenosis will come into TAW physiology. You have to look for the degree of pulmonary stenosis, pulmonary artery size, coronaries, collateral, PDA, source of pulmonary blood flow. You have to look on that. All these things can be defined by the echocardiography. Cath only required for the whenever images are not good, we go for the cardiac catheterization or coiling of the collateral in case of the collaterals. While with single ventricle physiology, we require cardiac catheterization only for the PA pressure and the pulmonary vascular resistance and the LV filling, ventricular filling pressure. So not for defining the anatomy, it is mainly for the hemodynamic assessment where we require the cardiac cath in single ventricle or by for the intervention like coiling of the collaterals. Admixture lesions are the lesions where is the mixing of the cyanotic and the acyanotic oxygenated and the deoxygenated blood is occurring there with increased pulmonary blood flow. It is with the TAW physiology, we have PS physiology, means PA pressures are normal, pulmonary blood flow is decreased. Here pulmonary blood flow is increased with or without high pulmonary arterial pressure. So this group include transposition of great vessels, total anomalous pulmonary venous connection, truncus arteriosus, single ventricle without pulmonary stenosis come into this group. For the TGA, I showed you the echocardiography or the transposition of great vessels. We have to define by the concordant discordant connections. Site of mixing, ASD. What is the size of ASD or the PFO, whether it is laminar or restrictive? VSD is there or not, PDA is there or not. These, one of the mixing site has to be there for the survival of the kid if he is coming to us. So we have to define, usually the presentation with transposition of great vessels is by 3rd, 4th day of life as PTA get restrict, ventricular septum is intact. So get very blue and child come to our attention. Here PFO is smaller, we have to do the septostomy, otherwise early switch by 7 to 10 days of life. So complete diagnosis must, then associated lesion we should rule out. Coronary anatomy is important because child is going for the arterial switch, means coronary transfer will be required, and left ventricle how it is prepared or not. Prepared means in first month of the life LV is prepared, after that it used to regress as pulmonary arteries are facing the pulmonary, LV is facing the pulmonary circulation. This is again same picture, pulmonary artery arising from the LV, bifurcating, PDA filling the pulmonary artery, and this is aorta. Very small VSD is here, this red flow. This is parasternal long axis view for the transposition of great vessels. What you see in subcostal view, very important, is this parallel great vessels. This is aorta, this is pulmonary artery, which is bifurcating. So parallel running great vessels are a feature of malpose great vessels. Here you are seeing the ventricular septal defect, tricuspid valve coming into way of the VSD. So parallel great vessels. And this is in parasternal long axis view. This is ventricular septal defect, pulmonary arteries. Here pulmonary arteries override the defect. While with normally related great vessels, aorta is the structure which override the defect. So VSD, pulmonary artery, and which is turning posteriorly. Normally aorta goes in this plane, just straight, while with TGA pulmonary artery tilt posteriorly, and this is the aortic valve which is anterior and just descend downward. This is echocardiography of a child with mesocardia. You can see how the heart is sitting just in the central plane. So this is mesocardia with large ASD. And inside the child has truncus arteriosus. This is LV, truncus, pulmonary artery arising from the common trunk. Okay, then come to the pulmonary outflow tract obstruction. With the outflow tract obstruction, we have to define whether it is for the left or right, whatever the site of obstruction, we have to look whether it is subvalvular, valvular, or the supravalvular, or into the distal vessel like peripheral PS or the coarctation of aorta. So site of obstruction we have to define, severity of obstruction we have to define, and what is the effect of this obstruction on the left on the ventricle, whether hypertrophied or dysfunction, we have to define. Okay, plus associated anomaly obviously we have to look. So the most important for the pulmonary stenosis is the how is the valve, it is thin or dysplastic, what is the size of the annulus, pulmonary annulus, and the severity of obstruction. Subvalvular obstruction with valvular PS is usually there because of hypertrophy, but it used to regress in the 3 to 6 month period of time. But muscle bridge we should rule out. If it is there, it is a organic obstruction, will require surgery. On the aortic side, again, you have to look for the valve morphology. Associated AR is there or not. Valve is bicuspid, tricuspid, or the quadricuspid. You can have any number of the cusp in aortic valve. So these things should be ruled out. Significant AR should be ruled out. Calcified valve should be ruled out. Then you can go for the balloon aortic valvotomy. And associated things, if there, will require aortic valve replacement. And again, the important thing, very important thing with the LV or the RV side is, whenever there is significant ventricular dysfunction, gradients are not reliable. Because we have dysfunction, our accordingly output will be low. So we will not get proper gradient. We will underestimate gradient. So we go by the total picture of the valve area, stenotic valve area to define the severity of obstruction. Then the coarctation of aorta. In pediatric age group, it is very easy to define the coarctation of aorta by echocardiography. You have to look for the arch in the suprasternal long axis view, arch vessels. Transverse arch is hypoplastic or not. We can go for the balloon dilatation or not. It depends on the hypoplasia of the transverse arch. Then associated PJ is there or not, aneurysm is there or not. How is the LV function? What is the gradient? And these things should be can be looked by the echocardiography. This is the suprasternal long axis view. This is the second arch branch, third arch branch. First arch branch is here, and this is the discrete shelf, very good for the balloon dilatation. And the gradient in the arch, if it is significant, it has to be continuous gradient signal, because in the great vessel we have the systolic and diastolic pressures. In ventricle outflow semilunar valve, we get only the systolic gradient, while with the great vessel we get the continuous gradient, because flow is there from systole to diastole. If it is significant, we get a continuous signal, whether it is pulmonary stenosis, peripheral branch PA stenosis, or the coarctation of aorta. Same thing applies there. The signal start in the diastole and spill into the start in systole and spill into diastole. So this is very important. If there is signal only in systole, it will be of means you may get higher signal, but if it is not into the going to the diastole, means something is wrong there. And usually they present with the high PA pressures, secondary to LV outflow obstruction. Then from the intervention point of view, we have to look on the ASD, like this is fossa vallis ASD, but there is no IV syringe. So child cannot go under device closure. So these are the small things which we should look while doing echo for the congenital heart defect and different views. Basic cannot make a description. We can stop here. We have to, the important thing is this, we should know what we are, like in the congenital heart disease, we should know, we should follow a systematic approach, sequential approach. Whatever the lesion, whether it is simple ASD or VSD or PD, or it is a complex heart disease, if you go sequentially, you can diagnose any complex problem, or you can assess hemodynamic of that particular heart defect. But if you just jump from one view to other view, or just define a particular lesion and just leave it, so your report obviously will not be
in case of adult, it is most of the thing, it is the confined structure. But in case of pediatric and congenital heart disease, it is like possibilities is like endless. So really we need to go by this systematic approach. And if you don't follow, and if you don't develop the habit of systematic approach, definitely probability of missing the things will be more. And moreover, as ma'am said earlier also, like you have to identify this structure, like because in many diseases some structures looks like other disease, other structure. So like left atrial, it has to be like identified by the appendages. Like this, there are the various things by which you have to identify it, and not only don't identify it by only seeing the one particular view. You have to make like see by the other structure, other view also, and make it confirmed that this is the really a mitral valve or tricuspid valve, or this is the really a single like ventricle or double ventricle. Otherwise, in case of adult, it is very easy. We all know that there are
even
two
in
ventricles.
Adult, like it's like corrected TG, AVVA concordance, no septal defect. They come with chest pain in adult stage, and they used to diagnose TR will be there. TR is very common to occur in the corrected TGA, and just MR, rheumatic heart disease, they've been followed by that. So that even you are doing the adult echo, connections should be clear. Always connection should be, because it is like ASD can present in this age group, corrected TGA, which is the commonest thing, most complex, and can present in adult age, which is asymptomatic or chest pain or arrhythmia, complete heart block. Any patient with presenting with the complete heart block, corrected transposition of great vessels should be ruled out. Epstein anomaly, mild Epstein anomaly, arrhythmia is a common association. So Epstein anomaly has to be ruled out whenever you came. But again, your comes as a sequential analysis.
Sequential. Because these are the most important thing. So as a conclusion, I would like to say that there are different views which you need to know, like in the case of pediatric echocardiography, like subcostal is the best, and after that you go by the apical view, you can go by the like long parasternal view, short parasternal view, suprasternal view, and moreover there are sequential analysis, and there are many fixed structure by which we identify this structure, and after that definitely you identify gradually like approach like different like acyanotic heart disease, cyanotic heart disease, or any obstructive lesion like aortic stenosis or pulmonary stenosis. And I hope all of you will be benefited by this program.